Hello, I'm Brian Little, Consultant Ophthalmologist and Training Director of the Cataract Service at Moorfields Eye Hospital in London. With every new surgical technique comes a new set of complications. The video you're about to watch, entitled Femtophaco Follies, is produced by Dr. Yeoh from the Singapore National Eye Centre. This is an excellent educational video. It begins with a wonderfully dramatic and fairly terrifying clip that, albeit somewhat sensationalist, sharply focuses the viewer's attention on the important subject of femtophaco complications. Using excellent quality video clips, Dr. Yeoh illustrates most of the common problems associated with this technology. These are pupil shutdown, incomplete or imperforate incisions, capsulotomy tissue bridges and tags, together with intralenticular gas bubble formation and small residual cubes of lens fragments at the end of surgery. What's very nice about this balanced video is that, as well as illustrating the complications that can happen, Dr. Yeoh also offers solutions to how they can be avoided in the first place or managed when they occur. Although some of these problems can be excused as resulting from the technology in its relative infancy, nonetheless, we all need to be aware of their existence and to embrace this surgical innovation as potentially important, but at this moment, imperfect. Thank you for watching this.
Welcome to Femtophaco Follies. Femtosecond laser-assisted cataract surgery, or FLACS, is gaining momentum, but new operation, new complications. Let's have a look at some challenges and complications facing the femtophaco surgeon after the femto step. On days like these, the first difficulty encountered is that of pupillary constriction after the femto step. Here we see the myosed pupil peaking the cut capsule. The completeness of the CCC is hard to ascertain, and nucleus removal is harder. The use of OVD to open up the pupil works in most cases. Post-femto laser miosis can be prevented by the simple expedient of applying 2 drops of a non-steroidal anti-inflammatory drug with the pre-op dilating drops. As with femtolasic flaps, femtolaser incisions can be challenging to open, and here a Sinskey hook is clearly the wrong tool. A specifically designed femto incision spatula opens the incisions up easily. Femto incisions are occasionally placed too centrally and should not be used. New keratome incisions should be made. Placing a femto incision over an area of arcus senilis or a pterygium also results in imperforate femto incisions. And now, on to Femtocapsulorexis and its problems. Here we see the dimple down technique taught to us by Burkhard Dick to free and remove the completely cut anterior capsule, which is now the norm for current generation femto machines. If the cut capsule with underlying adherent cortex is grabbed with a capsule forceps, a thick, odd-looking capsule results. Picking up only the capsule results in a more normal-looking capsular flap. This is an interesting case of a lost anterior capsular flap. The OVD injection was inadvertently made under the free anterior capsule and was not to be found anywhere. Until after the nucleus was removed, the lost capsule was found plastered to the back of the corneal endothelium, almost like a dissect graft. Moral of story: inject OVD above the free capsule. There is some controversy about the strength and completeness of a femto CCC. Here we see a femto CCC with a whole uncut quadrant. Truth be told, managing this large uncut capsule is not difficult if one is familiar with manual capsulorexis. It is harder reconciling the fact that such an expensive machine can fail to deliver what is promised. Tearing manually within the original femto CCC laser path results in this tongue-like flap where it joins the lasered capsule. this tongue of anterior capsule is easily removed. In general, it is better to tear from outside in when there is an uncut capsule. Tearing from outside in results in a smooth scalloped edge as seen here and no capsular tongue. Here we see one with a half uncut capsule. These two cases were from earlier generation femto lasers, and today the quality of smooth, complete femto CCCs is in excess of 95%. Potentially much more dangerous are the tags and irregular CCC edges that used to be common. Here we see a residual capsular tag and bridge. Another case of incomplete femto CCC, except that a capsular tag was not seen in this case and the IA cannula aspirated a tag which extended into a large crescent of anterior capsular rim. If this had not been appreciated and IA continued, a rip in the posterior capsule would have likely resulted.